Good morning, everybody. Welcome to our session in which have a wonderful group of practitioners here to discuss the intersection between the work that we do, which is street medicine, and the crises that our population, our most vulnerable population, finds themselves in during this pandemic. As a real brief introduction, street medicine is bringing health and social services directly to people who are living outside of traditional housing and even shelter systems. In other words, people who are living outdoors for whatever reason. Here in the States, we often say unsheltered. In Europe and other places, they're referred to as the rough sleeping population. I'm here in Pittsburgh. We have Nani in Allentown, and Mark is down near Philadelphia in Montgomery County. Our programs are a little bit different in terms of how long we've been doing this. And so I think that's going to provide a good reference point for people who want to compare notes with us and talk about the stages of development, if you will, of a program. But in all cases, the work has started with the awareness that despite all the amazing health systems that we've created, there are people who fall through the cracks. And in particular, the unsheltered homeless, rough sleeping population is one really profound example of what we would call exclusion. People who really, for whatever reason, are not embraced or connected or user-friendly, if you will, but also their reality is different enough that we can't often adapt our systems thinking to connecting with where they are. So it's a compelling group of people. It's a wonderful group of folks, but it's also a really good example of the disconnect of the reality between our systems and people that we serve. I'll give you a little bit of background about my program in Pittsburgh. I'm a medical educator. I'm an internal medicine trained doctor. And in 1992, because of my awareness that hospital-based healthcare had its own perspective, and as a medical educator, as a person who cared about our local community, I realized that for me and my students to learn how to learn from people who weren't part of our system, we really did need to get outside of the hospital and the standard practice settings. I wasn't sure how to do that, but I did have patients who were sleeping on the streets, one of whom froze to death back in the early 90s. And it led me to really seek out some way to connect with the people living outside. Seems like a long time ago, but in those days, I just found a guy who had been homeless himself in the past and was going out on the streets. And I asked him if I could go along with him. And he said, well, they don't really like doctors too much. And I said, that's kind of what I was worried about and why I wanted to begin this work. And so I asked him if I could join him. And I didn't tell the hospital, didn't tell my malpractice carrier. I just dressed down quite a bit and began making trips with Mike in the night times into the homeless camps. It was a real break with many parts of my world. It was a new world. I realized there were many, many people out there who were suffering physically, mentally, socially. Far more people than I would have realized if I hadn't had Mike as my guide. Their ranges were from kids, teenagers, to people in their 80s. Curled up next to dumpsters, and it was a very vivid period where I realized that there was this parallel world. People were very bitter and alienated from the health system. And many of them said they'd rather die than go to the hospital. Hopeless, anger. And yet there was a certain amount of pride of, we're still alive, we're surviving, we've got each other. And it was heartbreaking. It was hard to go home at night when it was raining outside or snowing, and just know the people now that were out there. From the hospital side point of view, when I talked to my peers and others, there was a lot of sympathy, but also a lot of, well, why don't they get a job? Why don't they just cooperate better? Why don't they come in? And so for a while, I had these two different worlds I was in, where I was running the clinic there at the hospital and on an inpatient service, and seeing the frustrations of trying to work with a population that didn't fit the boxes. And then when I was sitting next to the campfire or in an abandoned building, I could really understand the confusion, the fear, the barriers to care that people were experiencing in terms of the complexity, lots of catch-22 situations. And so I didn't know exactly where to go with all this, but I knew I couldn't stop going out, and I couldn't stop being present to the people that I was growing to love and care for. As with many things, once you get started, others begin to hear. And so initially it was a couple nurses and a social worker. They always seem to catch on quicker than the doctors, but they began to come out with me, and pretty soon we set up teams where each of them had a formerly homeless person on their team. And we began making regular visits. Even if we couldn't solve all these problems with folks, at least we'd be present to them. And we began to address issues. Some of the medical crises, we put medicines in our backpacks, and we began to get to know the community in terms of who to call, where to go, stuff that I never would have really learned if I hadn't had to look it up and get to know for the sake of the person in front of me. And so I like to think we begin to weave ourselves into the fabric of the streets and into that community. The folks that came out had a certain value system, I think, but the work reinforced such values as respect, unconditional, positive regard for people, no shame and blame, harm reduction, infinite flexibility, honoring the reality of the person in front of you, doing whatever it takes. And we have lots of funny stories about that over the years. I'm sure you guys do too. But there was an excitement and an energy that we got from being able to be there for people no one else would be there for, and to do the right thing, and give somebody hope where they previously had none. We also, of course, began to see the strengths in the individuals that we served, not just their shortcomings, but their courage, their strength, the leadership within the street community, which you might not have been aware of, that's out there. People look out for each other. And so it was a very humbling and sacred place to be. And as we grew, we were able to then begin to connect back with our medical system. So now we're facing a crisis as a community, and we're aware that there are people who are always left out or always left behind. Typically, people on the street tend to be overrepresented by people of color. At least 50% or more in our Pittsburgh community are African American. In other cities I've traveled to, the native population is overrepresented. Groups such as the LGBTQ community, in some studies up to 40% of the youth that are homeless are there due to difficulties with their families and society regarding gender issues. And so it's kind of a catch-all for people that have already been beaten up, already been traumatized. And so we have to learn how to work with a trauma-informed model to stay with them wherever it happens. I'm going to quickly pass this on to Nani so that and Mark so that they can speak a little bit. But I'll say that this isn't the first crisis. It's the biggest crisis I think that we faced. But street homelessness is a chronic disaster. It's a chronic crisis. And one of the first that we encountered here was 11 nights of minus 20 degree Fahrenheit weather in Pittsburgh in the 93, 94 winter season. It was awful because we knew these people, we loved these people. Some of them, could make you pull your hair out, but you weren't going to give up on each other. And we could see that the shelters were full, and in some cases the shelters had rules such that you broke a rule last year, you're not allowed in, and it was minus 20 degrees out, and people were going to die. And so we had to reach out to other people in the community as to how we could possibly address this. And we basically took over a building downtown and put people in there. And then we began to really work with the county government. And they said, you know what, this is a great thing. We'll fund this. And so we're now in our, I don't know what year it is, but almost 28 years of having a winter shelter, which we run every year. And we do it with other agencies. It involves housing services, mental health services, people providing food. And it's a really collaborative linking of the community. The homeless spread the word themselves, about the shelter and help engender trust because we have a very low barrier attitude towards it. And so that was one of our first ways of trying to kind of pull together as a community to make it work for the people who otherwise it might have been very difficult for them to get the service that they needed to survive. So we're facing the same kinds of dynamics over a longer time period now. And I think most of the street programs have used the same strategies, which is to, first of all, make sure that our relationship with the people on the street is not broken, that we're there on a regular basis. So we had to adapt our procedures and our PPE and all those things. In Pittsburgh, we were able to get people in a number of camps, washing stations and water and toilet facilities, information about COVID. As other services retracted, we had to find new partners to bring more food directly to people, and then began to work with the county and Department of Human Services, who've been wonderful, the shelters and others, to create a more of a seamless environment for all the things that we needed in terms of isolation and testing and all those kinds of things. I'm going to stop now, and I can answer questions about how we addressed COVID or are doing so now. Later, I'm going to give us all a little time to have some interaction with each other. But I wanted to maybe let Nani talk about their background, their work, and how they're responding to this pandemic. So you'll have to unmute, Nani.
All right, thanks. Thank you, Jim. I think we're going to find that everybody's in the street medicine anyway, very similar situations. But one of the things that I think I've learned the most in trying to support during COVID is that our folks that we serve are really way ahead of us. They can survive a much more tragedy. They just shouldn't have to, but I think they have really shown us how to really be flexible and roll with the punches as they've had tragedy upon tragedy. And this has kind of been a chronic state for them. For those who don't know, my predecessor, Brett Feldman, worked with Dr. Withers many years ago to start the program in the Lehigh Valley. So a couple of years ago, I assumed this. My work as a physician assistant had been for 16 years in the emergency department. And I think just to understand my background, I felt quite useless, actually, because I dealt with just the problem and the concern that somebody had when they came right to see me. And I didn't look at their circumstances as to why they were where they were. And so it felt very half-assed, because it really was ineffective. I was dealing with the rash, but not really dealing with the reason they have the rash, is because they're laying in feces or urine and they're outside. And so I think it really felt very incomplete. And so when I started to volunteer with Brett Feldman, I realized I'm doing a lot of work internationally, spending thousands of dollars going abroad to serve, when I've got a community right in my hometown that is really suffering, and I'm probably walking over them to get to the airport, to get to Uganda or Haiti or wherever I was going. And so it really was eye-opening for me, and such a blessing to be able to do that. And so I think sometimes we forget, and my encouragement to whoever's listening is that our community is so special. And I think we really forget sometimes that we have actually a lot more fun and accountability. I think, I can go to Honduras twice a year and see people, and they're happy to see me, but there's nothing better than walking down the streets of Allentown and having, Kevin shout from across the street, "Hey, doc, the rash is better," or, "Hey, it's not better. Like, what are you going to do about it?" And I think there's something really special about that accountability. And I just couldn't imagine doing anything else. And so I think as we look at things that we've learned and resources that we've kind of made available for COVID, I wanted to share some of the things that we've added since Brett started and built Roots for us. We've added some services for our patients that really, I hope they would say that they're patient-led. And so what we found is that very quickly, I learned things that we weren't doing as a medical system. And so we started to ask, why aren't we, and what can we do to supplement? So, during COVID, of course, a lot of the social services closed. And patients said to us, "I need a mailing address. Can you give me a mailing address? I don't need blood pressure medicine." And so their lack of connection to get mail, to get government benefits, really was very obvious to me pretty quickly. And so I talked to the hospital and said, "Well, can we have a mailing address for our patients?" And so it took some time, but we were able to actually then get a mailing address and receive mail and government benefits on behalf of our patients, so that they could get Social Security, they could get SNAP benefits, they can get things that they needed. So that was a way that we pivoted to try to help our folks get what they need, which they weren't asking for medicine from us, they were asking for a mailing address. And so we heard them and added that as a service that we could. And it was a great excuse, really, to connect with folks. When we would see them, we would be able to bring their mail, now their checks. So, it's been a really lovely way to kind of introduce what we do. And when folks have medical needs, then we can actually add to that. Another thing that we offered is we started to partner with our municipalities to offer COVID quarantine. And what that meant was partnering with a local hotel and our Meals on Wheels and our local municipalities to be able to offer folks, when they had COVID testing and they needed to wait, rather than send them back to an encampment, that they had a hotel that they could shower and get food. And so we added that as a service, that we would check in on people. Of course, if they got whisked away to the hotel from the testing site, the COVID testing site, they're often without clothing or food, and at least initially, until Meals on Wheels was started. So we were able to provide and supplement medication if they needed it while they were waiting for their test results. So that's something that we added as COVID really started to rear its ugly head. We also saw that we needed to really increase psychiatry. And so, of course, anyone that has regular insurance really realizes that we can't, I can't get into a psychiatrist if I wanted to. And so how are our folks that have enough barriers going to be able to deal with, how are they going to manage that? So we were able to get a grant that allowed us to bring an iPad to them in their encampment at a soup kitchen, out wherever they needed to be, to connect them to a behavioral health specialist to just talk to whether it was connect them to a psychiatrist in an outpatient basis, whether it was to just to have someone to talk to because their counselor was no longer doing face-to-face and was only, and if you wanted to have a virtual visit, you needed to have a smartphone. And so we tried to kind of eliminate those barriers and found that that was hugely effective. So we were able to really connect with folks by bringing an iPad to them so they could just have some communication, and we would go do something else while they were having a session with a behavioral health specialist. And it really felt that was effective in at least alleviating some of the stress that our folks were having while they were being disconnected from services that they relied very heavily on. Another thing that helped, I think, during COVID, and probably the last thing that was a pivot and an adjustment to what we did, is we were able to apply for a grant for respite care. And while we had respite care before, it was only for males because we were partnering with a male shelter. But this allowed us to be able to partner with a local hotel, much like the quarantine program, and offer folks during times of COVID to really, they weren't sick enough, obviously, to stay in the hospital, but too sick to really return. So it allowed them space to heal and recuperate. And so during COVID times, we were able to really reach out to folks that needed surgery but didn't get it because they didn't have a safe place to heal, or maybe needed a little extra time. And with the lockdown of visits and the lockdown of really having people coming in and out of the hospital that we were serving, I think we found that respite really was a wonderful answer to that. And so I think those were some of the things that we did. And we also increased our street rounds. So we spent a lot less time going into shelters. We spent more time with our rough sleepers, trying to make sure that they were healthy, that they were connected, they felt connected, that they got information about COVID, and that anything that they needed, that we tried to really make sure that they didn't feel disconnected from the world, because we were finding that COVID really exacerbated what was already tough for them to begin with. So I think those are some of the things that that the Lehigh Valley did to pivot during COVID. And I hope that helps, and look forward to answering questions if anyone has any after Mark is able to speak as well. Thanks for the opportunity. I'm going to mute myself so I don't do something stupid.
Good morning, guys. Thanks. One of the benefits of going last is that you get to hear everybody else talk first. And I am impressed every single time I hear Dr. Withers and Nani speak that it's not just the service. It's not just providing a service. It's really about connecting to the human experience of being homeless. What does it mean to live life that way? And how do you connect to it? Be proximate with it, enter into it respectfully. You heard the values that were spoken of. And then also how to learn from it. If you're humble enough to sort of pay attention and listen and enter into that relationally. So I'm just struck again by that's really the foundation for any of the work that we do with folks who are living outside. We're the new kids on the block in a way. We have, in 2020, we started a pilot project, a grant-funded pilot project to partner with medical providers in our area to begin to do street medicine in Montgomery County. I work for Access Services. We do a street outreach program, an outreach program it's more of a social service than it's not a medical program. And so we've had to figure out how to partner with medical providers in our county to do this. I'm happy to say that our first set of rounds is going to be in 2 weeks. And it was a lot of work to do two things. First of all, respond, pivot, as we've heard, to the immediate needs that happened. Dr. Withers referred to it as a disaster, and I think it was helpful for us to understand that this is a pandemic. It's a disaster for the folks who are living outside, and to see the significance of it in that light. I think so. We're very close to starting that. I think another thing, there was the theme of how social services were becoming constricted during the stay-at-home or during the lockdown. Our outreach workers were still out, and so we were still out in the community with those same people in protected, but the same way. And so trying to figure out how to partner with everyone else to continue to meet the needs that people had. I think I realized the significance of this. It was mentioned how people are marginalized. It's just being homeless in the community is a marginalized thing. But I think I realized the starkness of it, the reality of that, like about 2 days after the stay-at-home order happened. I knew this was going to be a hard thing in my head, but I ended up talking to a man, Charlie, who I knew. Charlie's a very smart guy. He's very good, as Nani had mentioned, he's very good at survival. He knows how to be outside, but he was describing to me all of the things that he didn't have at his disposal suddenly overnight. He was distraught because he was worried about the virus. He wanted to keep himself safe. He also understood that this was about community health, and he wanted to make sure he didn't give it to anybody else. And he had no mask. He said he had a little bit of money, but wasn't sure where to get one. He had a tiny little bottle, half empty, of Purell hand sanitizer. He said, there's only one bathroom, and it has a sink, but there's no soap and there's no towels. He said, I would wash my hands 10 times a day, but I can't. And so, and he and I were standing in a transportation center, and this was Easter morning. So it was kind of, Dr. Withers talked about sort of that juxtaposition of there's the world, and then there's this other world, this sort of parallel world where people are trying to survive and live outside. And at that moment, somebody had decided that a good idea would be to remove all the benches from the transportation center, as if that would somehow help the homeless people not be too close to each other. It didn't. It just meant that everybody was sitting on the floor. So it was interesting. It was sort of visceral for me to just sort of be in that moment with him and listen to how much he needed and how hard it was going to be for him to just manage the upcoming period of time that none of us knew exactly what was going to happen. But however hard it was going to be for me to live through a pandemic, it was going to be exponentially harder for him. So I think I was struck just by that. So a lot of our work during that period of time was to figure out, as has been mentioned, what are the creative or innovative ways that we can sort of fill those immediate gaps, those needs for relief. So we partnered in ways that we hadn't even imagined with just members of the community, faith organizations, different groups, to do things like make masks and distribute them. We partnered with the people where folks were going to get food, to be distribution hubs for us to make sure that we could get those things out to people as much as possible. We had them as an outreach team, but we realized that getting them to other people as sort of distribution hubs was really much more effective. We participated in a porta potty campaign. So we worked with municipalities. Where can we put toilets? At the risk of being crude, my line was, shit happens, but where? And it just really wasn't a place for people to go, even that basic stuff. So we participated in that. And then sort of on a little bit of a bigger scale, we also got a grant to distribute iPads to places where people were going regularly, with the idea that they could get real-time connection to services, particularly Access Service. that has this program also has a mobile crisis program in the county. So how can we get people connected in real time using technology and leveraging that? So going beyond just cell phones or just phone calling, and how do we connect people in real time to services they need? And how do we do that at places where people are going anyway? We also got a grant to do medical respite, and that's a more recent thing in our year. So we're still in the process of unfolding that. But as Nani also mentioned, we have people that we've seen who have really big health needs, and they're not getting them taken care of because they don't have a place to go afterwards that's safe for them to recover. That is a chronic need. That's always been there, but it's been exacerbated certainly by the pandemic. And I think one of the other lessons learned was just the importance of creative partnerships. So that included other partners who were providing services. How do we do this differently, and how do we leverage up our capacity to work together? We started partnering with just members of the community at large. One of our mottos is that homelessness is a community issue. It's a community, and part of the solution lies in the community itself, not just in the service providers of that community. So we actually have every Friday morning Zoom meeting with anybody from the community who's interested. And we've figured out how to increase shelter space. We've gotten the community to do donation of really specific personal gear. One of our goals was to help people who are outside be outside as safely as possible, knowing that they can't get inside the way they did a year ago or a year and a half ago. So good socks, good hats, what's the best gear that people can have? So we have donations coming in because the community has responded to that specific ask. We also had a goal to set up intentional spaces for people to be. In Montgomery County, they're not big tent cities, but there are dispersed encampments. So helping people in those encampments be safer, having a heater makes a big difference. So figuring out just how to equip them to be outside intentionally as safely as possible was a really big part of that. And then lastly, I think another thing that's come out of this is we realized that telehealth is a thing. As providers, we're sort of all thrown into the deep end of the pool to figure out how they can continue to do their service on a telehealth platform. That wasn't done equally. Like some folks were better at that quick pivot than others. We realized that there is really high-end medical equipment that can help people be connected to a doctor virtually in real time. And so we are also in the process of in partnership with our local health providers to purchase and start using that equipment as an additional tool in our box to increase the point in time access that people have to healthcare. So again, I'm happy to talk more and listen to questions as we move forward. That's sort of where we've landed in the whole COVID experience that was 2020.
Thanks, Nani. Thanks, Mark. That was really insightful and inspiring. I'm going to jot some of your ideas down and steal them for our city as well. So I think one of the trends that we saw, and it was reflected in the other speakers as well, was a sort of how do we as a community respond to a crisis? And one of the unfortunate things that happens is that we look out for ourselves, and I noticed in the earliest days of the COVID pandemic that there was even a higher level of stigma, a higher level of assumption about the people living on the street than there had been before. Some of the folks that were working with our population even began to get stigmatized and rejected by friends, et cetera. I've experienced a little bit of that myself. And, at a certain level, it's understandable. We don't know where it's coming from, where it's going. But it's very obvious when you're intimately connected with people how much prejudice there really is, and how many much of an assumption there is that dirty people are the source of all bad things. And so we committed ourselves very early on to testing. Testing wasn't available at first, but we, just like Mark said, we found creative partners. We put out feelers, but people found us as well. One of the things that the street medicine program has to do is make its presence known to the community so that good people can dialogue with you and give you resources, et cetera. And so we had a researcher at the university who was already set up to do viral testing, provide us with some of the very earliest COVID test kits that anybody had here. And through that, we were able to establish that we had virtually no positives in the street community. As time went by, it became clear that the unsheltered population, far from being a source of contagion, were probably people that we had to be careful not to infect, because the prevalence was lower than it was in the general population, in fact. And so our thinking, even within our organization, humbled us a bit, and we had to flip the script yet again to see the issue in a different light. I think the things that I didn't mention that we've done as a community, which are a bit of telehealth. I really like Nani's idea of specifically focusing on psychiatric access, because that's one of the things that's most difficult. Early on, telehealth exploded in Pittsburgh, but it was obvious that it was a class thing where only people that were really set up with good office practices were going to get it. And so we were able to get our own iPads and initiate that as well. We, with the county, they really were the main people in this, were able to get a hotel in which people who were both vulnerable, high risk, could go to one part of that hotel system, and people who had symptoms would go from the shelters or wherever, who didn't have housing, into the other quarantined area. And that's actually worked out really well. The Medical Reserve Corps was able to step in. Most places in the country have those to provide a lot of the care. But again, we got a much closer relationship with our county health department and with our Department of Human Services. We have regular calls to coordinate those activities as well. Our winter shelter has been a challenge. We've had to adopt new practices, reducing the number of people, having screening at the door, a quarantine area within our winter shelter, on-site testing, which we do at least once or twice a week, and streamlining training and having a lot of attention to how we do every little detail of the shelter to decrease the risk. Fortunately, we still have no positive cases in our shelter at this time. So I think it's just when you're there with people. Our tagline for the Street Medicine Institute is "Go to the people," and I think you can have all kinds of great ideas from a distance, but the only way to really respond to health needs, social needs within your community is to find a way to be there. It helps to improve access to your clinics and your other things, but I think it's just really, really important. It's been shown during this time that there's no substitute for, having Larry wave and say, hey, the rash is gone, from across the street. That network of people will let you know who's in trouble, what's not going well. You may think your plan was great, but when it is seen from the street level, there are often some big problems with it. And so I do think that the model of street medicine, which could be applied, is applied to other populations that are excluded, I think is probably the take-home message for me, is that if you're part of the system or part of the community, listening with the right spirit and with partnerships that are new and creative, that's really the way that street medicine, the folks from the streets, can teach us how we should probably reshape all of healthcare. So we have about 15 minutes left, and I'm going to ask Kate maybe to open up whatever questions she might be collecting so that we could try to address them or learn from people on the call about their experiences as well.
Okay. No questions yet?
Okay.
Could I just jump in for just a second? One of the things that I was also struck by when you were just talking, Dr. Withers, was one of the things what we've done is we've managed to, we're talking about creative partnerships and also how to get people connected. Like, how do you be with people? And one of the things we've started is that we have groups. So far they've been faith groups, but they adopt a site, and so they get to meet the people in the site. And so David and Shirley are this couple who are living outside right now. They have 3 cats. They lost their housing directly because of COVID, and Shirley has some health issues. This church resupplies them. They help them with food, they help them with sanitation, they help them with trash removal, they help them just with a lot of things, but it's really the relationship. So I'm with David and Shirley. They talk about the people that have come and hung out with them. But part of that, it also is that some of the church folks came back to me and said, Shirley says she can't afford some of the medical work that she needs done. How do we help that? So now there's a whole group of people who are now paying attention in a whole different way to the folks who are outside. And so I think this is just a big lesson learned for us, for me, is how do we include the community in this? Because there's the homeless community that functions like a community, and then there's this other community that's the rest of us, and there doesn't have to be the gap. And there's a lot of stigma and a lot of reasons why there's barriers set up, but we can figure out, hopefully moving forward, ways that we can leverage what we've learned into doing things in a different way.
Yeah, it's so easy when you're sort of doing this for a job to think, step aside, we're the people that know how to do this. And then you really cancel out an enormous potential for folks being able to bring resources, but also great ideas. And then ultimately, I think the best thing that's really happening is that people are feeling their connection to each other. And that's what you want to be contagious, not the virus.
Yeah.
One of the things that I was going to share that was really helpful. We have a really creative grants department who saw that there was a bunch of money that's just kind of sitting around from a bunch of different departments that really had no purpose, people that had leftover grant money that didn't use it. And she was very creative. She said, let's create a Friends of Street Medicine grant opportunity. And what she did is she collected all the little bits of money that, and ended up being almost 40,000 that she was able to collect from various grants that weren't fully used. And she said, who are the partners that are suffering? So, the hospital sometimes has a bad rap around here as being kind of this monstrosity that looks out for number one. And sometimes that is in fact true. But what we realize is our partners that are doing such good work, we can't repeat that. In fact, we can't do the things that they do. We have to stay in our lane and really celebrate the work that they're doing to support the same community. And so she said, who are your community partners that are suffering during COVID? And so we gave her a list. She sent that list to each partner and then said, submit what you want, like what do you need during COVID, and give me a budget. And she approved everybody's requests. You know, the soup kitchens now needed to-go containers, which they didn't have money for. And so now that they're not having sit down, they needed all this to-go stuff that cost money. And so, you know, people were now shelters need, you know, sanitation items to clean, you know, more fervently than they did before. So it was a low barrier grant that she created, and I can't take any credit for it. I was just, you know, impressed that she could collect 40 grand from bits that, and then just offer it. And there wasn't one community partner that wasn't able to get something that they needed. You know, one of the shelters needed, now they had kids stuck at home, so they needed kind of activity booklets for kids. And so she created, they were all bored and beating each other up and going crazy in the shelter. And so what do we do to kind of mitigate that? And so it was just a clever way of coming together and staying in our lane, but trying to support the smaller nonprofits that were supporting our folks. And it was super exciting to actually see it come together. And so I kudos to, you know, clever grants persons that can think about how do you take scraps, put it together, and actually put it in a meaningful way to help support folks that are doing great work that we could never do as a network without them. So I just wanted to share that. It reminded me as we were talking about kind of fun and clever ways to support our community partners. That was one of the things that our grants person thought of and was really well received.
Again, a reminder, there's a Q&A tab in your live stream, and you folks are most welcome to enter your questions, and we'll try to address them in the time that we have left. Nani, one of my old surgical classmates and some others, there's a wonderful program, 412 Food Rescue here in Pittsburgh. They got together and they realized that the restaurants were in trouble in terms of their ability to keep their businesses going. And so they organized to have a number of restaurants participate, and people would donate and buy money from the restaurants. And then this gang would pick them up and then deliver them to programs like ours for distribution. And so we could meet the need as well. So I love stuff like that.
Yeah, I love that. I mean, everyone's suffering, and it was just a really great way. And it was a low barrier for, you know, for smaller organizations that usually have papers and papers and papers to fill out just for, you know, a small bit of money. You know, it was lovely to see, but I love that restaurant idea too. I'll kind of, if we get in that, stuck in that again, I think that's something I use.
We also went to Facebook. We set up a community Facebook page where we could just put out really specific asks. And then people from the public could just meet that need. And it wasn't just the idea of donating towards a need. It was people are actually connected to each other directly. So we had a gentleman who needed to go to the hospital, and he was very fearful of that. And it took him a while before he got ready enough to go get the procedure that he needed. His wife needed to be closer to him than the encampment was. And so we just put out to the public, she needs some hotel nights. And we didn't necessarily have it in our budget. It wasn't a service thing, but we went right to the community, and people responded, and they put her up in a hotel for the duration of time that he was in the hospital. So he didn't have to worry about her. She was close enough that she could get to the hospital on her own. We had other people that volunteered to drop off food to her at that hotel because she was out of her normal sort of where she went to meet her own needs. And so it was simply the power of social media connecting in real time.
Putting a face on the folks that are suffering, We're all about story. I think that's really important to give folks a sense that they're part of some larger story that they can contribute to. One of the things that I guess I'd like to prompt myself and the rest of us to think about is how are we going to serve our populations, excluded populations, as the vaccinations become available to them as well. We're sort of piloting that with giving our flu vaccines at our winter shelter and getting partnerships of folks that can come in and help us with the paperwork and everything like that. But that's just one I want to throw out to the audience and to you guys as well for any thoughts you might have, suggestions you might have about how can we make sure that they get the vaccinations if they're able. And again, there's a lot of issues there about building trust and the stigma and educating folks on it as well.
Jim, I can't see questions. Is there anything that you've seen popping up?
No.
Okay. You must be answering it all.
Kate? Yeah.
No questions yet.
Okay. That's a good point about COVID vaccinations. I think what our team has been trying to do now is just kind of start the conversation, knowing that it's coming, and really start to build the trust. I have to say that our team kind of needed to be re-educated because we were a little skeptical ourselves. So we really had to work with our infectious disease team to be re-educated, to make sure. I just was a little paranoid about how come it, we got it so quickly, and why, like, what's the safety and blah, blah, blah. And so I think once I started to feel comfortable the way things were processing, I think I can speak a little bit more confidently to our folks about the vaccine when they want it. So, but I think really our team had to really kind of fix our preconceptions and really work on that. So I think now that we've done that, we really need to start laying the groundwork to prepare our folks for when they're ready.
I can't not say if folks have questions about street medicine, I'm sure there's contact information through this event, but you could also check out the streetmedicine.org website. It's a international group of people who are committed to developing and improving the practice of street medicine and advocating for folks on the street.
I typed my contact information into the chat, so if people want to reach out, I'm happy to continue to have conversations on our end. I think that one of the things we've been focusing on is just the conversation itself about the vaccination and the context. That it's that relational piece of it again. So for a lot of the folks that we serve, their context with the medical world, and also perhaps with shots is a scary one, or is one that was negative in the past. So just being aware of the context that people are operating in. So for example, a lot of the folks that we serve who have a history with mental health services, at some point in their life were told they have to take a medication whether they wanted to or not, and regardless of what the side effects might be. And sometimes that was done involuntarily. And so knowing that that's a driver of the decision, probably more so than an understanding of the specifics of how the vaccine works. Both of those things are important. People's knowledge of the vaccine itself, as Nani had said, like, do you know how it's made, and do you know how it works? And just giving that information is super important. But it's also important for us to relationally understand the context that somebody's coming to that decision from.
Well, I can say that I took a detour back in '92 to go under bridges and in abandoned buildings and such. But it really, it gave me an opportunity to really have a much better career and a life than I ever would have imagined. It's rewarding, but it's also fun. The human connection is something I think that we as healthcare workers need. We get dehumanized by the way that the business has been moving. And I do think we have to fight for our own humanity. We have to fight for significance that we can enjoy, and the humanism of ourselves and the people we serve. And so I would recommend street medicine, but I would recommend looking at your own communities in terms of looking for a way to connect in these ways. There is a question, 2 questions now. The second question is there any data on the number of sheltered communities, number of COVID infected? The only data I know right now are some studies that came out of Boston in which Jim O'Connell and his gang looked at, I think it was the Pine Street Inn and others, where they were shocked to find about 30% of their sheltered homeless community had positive COVID testing. He was also amazed at the lack of symptoms, for the most part, that the folks had. It does seem to be, as with other populations, the older you are, by far, is the highest risk factor. But certainly being indoors, breathing the same air affects anyone in terms of risks. The other question was tips for rural areas and how to start. I'm going to say really fast, because I think we have a minute, that get to know the people in your community that are working with folks experiencing homelessness. And that's going to be soup kitchens, it's going to be churches, it's going to be, and so you're going to need to buy a couple notebooks like I did and start making calls. I was going to say drive around and meet people, but that's not right now the best idea. But try to find out as much as you can from anybody who works with the homeless. Healthcare for the Homeless usually has a connection in many communities, which is a national organization. But then you're going to need to just start eventually getting to know the people themselves, because they have their own networks of places to go and things to do. The same principles, and we'd be happy to talk to you at the Institute, can be applied, I think, to reaching into the more hidden rural homeless populations. There's a number of programs from small towns that are part of our network now, and we could give you tips.